Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, High-Dose Cytarabine in Induction Treatment Improves the Outcome of Adult Acute Myeloid Leukemia Patients Under the Age of 46 Years, Results of the EORTCGIMEMA AML-12 Trial by Rolev Williams et al. My name is Jon Arneson, and I am an instructor in medicine and staff physician in the Division of Hematology Oncology at Beth Israel Deaconess Medical Center, Harvard Medical School in Boston, Massachusetts. My oncologic specialty is hematologic malignancies and bone marrow transplantation. Standard induction chemotherapy regimens for acute myeloid leukemia, AML, combine infusional cytarabine at a dose of 1 to 200 milligrams per meter squared for 7 days with 3 days of bolus anthracycline. With standard induction, 60 to 80% of patients can obtain a complete remission. A number of prospective and randomized trials have studied the use of high-dose cytarabine, 2,000 to 600 milligrams per meter squared per day for 8 through 12 doses, in induction for younger patients with AML. These studies have suggested an improvement in response rate at the cost of increased toxicity. In this, the AML-12 study, the European Organization for Research and Treatment of Cancer, EORTC, and the Gruppo Italiano Malati Hematologica dell'Adulto, GIMEMA, compared the efficiency and toxicity of induction using standard dose cytarabine to induction with high-dose cytarabine in patients with AML. In the study under discussion, patients aged 15 to 60 with untreated de novo or secondary AML, as defined by the World Health Organization, were eligible if they had acceptable performance status and no evidence of concurrent organ dysfunction that would compromise therapy. The primary endpoint of the study was overall survival, and secondary endpoints included complete response rate, disease-free survival, toxicity, and rate of autologous or allogeneic stem cell transplant. Upon enrollment, patients were randomized to standard or high-dose cytarabine and stratified by center, age, performance status, and total leukocyte count. Standard therapy was based on the EORTC-GIMEMA study AML-10 and included daunorubicin 50 milligrams per meter squared daily on days 1, 3, and 5, and etoposide 50 milligrams per meter squared on days 1 through 5, in combination with 10 days of infusional cytarabine at 100 milligrams per meter squared in the standard arm, or 3-hour infusions of cytarabine at 3,000 milligrams per meter squared every 12 hours on days 1, 3, 5, and 7 in the high-dose arm. Response was assessed by day 31. Patients obtaining a partial remission received a second cycle of induction, identical to the first. Patients obtaining a complete remission received a single cycle of consolidation and then proceeded to allogeneic transplant if eligible, or to autologous transplant if not eligible for allogeneic transplant. Between September 1999 and January 2008, 1,942 patients with a median age of 45 were randomized. 53 randomized patients were ineligible but followed on an intention-to-treat basis. 1,900 patients started induction, 951 in the standard dose cytarabine arm, and 949 in the high dose cytarabine arm. The two arms were matched in regards to baseline characteristics. 68% of patients obtained a complete remission in the standard arm, and 75% obtained a complete remission in the high dose arm after one course of therapy. This difference met statistical significance with a p-value of 0.009. A similar number of patients died during induction in both arms, and a similar number of patients went on to receive a cycle of consolidation. The overall survival rate at 6 years was 38.7% in the standard arm and 42.5% in the high-dose arm. This difference approached statistical significance with a p-value of 0.06, though when stratified for cytogenetic features and adjusted for several other risk factors, this hazard ratio favored high-dose cytarabine. A number of planned subgroup analyses were performed. In patients aged 15 to 45, complete response was better with high-dose cytarabine, 82.4% when compared to standard dose cytarabine, 75.6% with a p-value of 0.01. The 6-year event-free survival was better in this younger group with high-dose cytarabine, 43.6%. The 6-year overall survival was also better with high-dose cytarabine in the younger population, 51.9% versus 43.3%, with a p-value of 0.009. Younger patients receiving high-dose cytarabine had a significant improvement in overall survival in both secondary AML and de novo AML. Younger patients had improved disease-free survival if they had a related donor available and proceeded to allogeneic transplant in both the standard dose and high-dose treatment arms, 57.4% for related donor versus 39.5% for no donor in the standard dose arm, and 62.6% versus 46.4% in the high-dose cytarabine arm. In older patients, aged 46 to 60, the complete response rate was higher in the high-dose cytarabine arm, but this improvement did not result in improved event-free or overall survival, secondary to an increase in deaths in complete remission. In the older group of patients, complete response was increased with high-dose cytarabine induction in secondary AML and AML with very poor risk cytogenetics. In the older group, 6-year disease-free survival was approximately 35% regardless of donor status or treatment arm. There was no significant difference in the incidence of grade 3 and 4 non-hematologic toxicities or infection in the two arms. Grade 2 or 3 conjunctivitis was more common in the high-dose treatment arm. Hematologic recovery was similar in the two treatment arms. Based on these findings, the authors conclude that treatment with a high-dose cytarabine induction regimen results in higher complete response rate and improved survival relative to the use of standard dose cytarabine without a significant increase in toxicity. This conclusion is driven by the experience in patients aged 15 to 45 who had an increased response rate in event-free survival and overall survival without an increase in grade 3 or 4 toxicities. What does the trial tell us about induction chemotherapy in AML? Past studies that have attempted to increase cytarabine induction dose intensity have demonstrated variable improvements in response that is tempered by increased toxicity. Nearly 2,000 patients randomized, the EORTCGIMEMA AML-12 trial is the largest trial addressing the question of high-dose cytarabine in AML induction and the first to demonstrate statistically significant improvements in response and survival. Of note, an improved complete response rate was seen in both younger and older populations. The event-free and overall survival at 6 years was tempered by an increase in deaths in remission in the older population. Also of note, older patients with very poor cytogenetics had an improvement in response to high-dose cytarabine, which translated in improved 6-year event-free survival, but not overall survival. These findings are consistent with a clear therapeutic effect of high-dose cytarabine in AML induction. Prior studies may have lacked the power to demonstrate this difference. While compelling, the interpretation of these results is complicated by a number of issues. First, the induction regimens are based on the EORTCGIMEMA AML-10 study and included 5 days of etoposide. Second, following a single cycle of consolidation, younger patients with an available donor proceeded to allogeneic transplant regardless of cytogenetic risk. Third, patients without an allogeneic donor were consolidated with an autologous transplant. These 3 elements of the trial differ from the current standard of daunorubicin and standard dose cytarabine induction, followed by allogeneic transplant for high-risk patients or high-dose cytarabine consolidation for good-risk patients. Regardless of these differences, the convincing improvement in complete response rate in the younger population receiving high-dose cytarabine in induction suggests a clear treatment benefit of this strategy. Unfortunately, this benefit was not seen in the older patients in the study. Given that the median age of diagnosis of AML is 70, and the worst prognosis of AML in older populations, it is disappointing that the benefits of high-dose cytarabine induction did not apply. Over the last 40 years, survival in AML has increased through the development of improved supportive care and the evolution of the use of anthracyclines and cytarabine-based induction regimens. The findings of the EORTCGIMEMA AML-12 study continue this tradition of improvement and suggest a clinical benefit to younger patients with the use of high-dose cytarabine in induction. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.